This is Hector Gonzalez. I'm a professor in neurosciences and also with the Shiley-Marcos Alzheimer's Disease Research Center. And I'm really delighted to have David Loewenstein here with us. I've followed his work for many a year, and we've had a chance to interact some. And he's a professor of psychiatry and behavioral sciences at the University of Miami. He also has a secondary appointment in neurology. I could go through his pedigree and the like, but for those of you in the neuropsychology field, his I think over 200 publications as of recent. David, congratulations! Really speak for themselves, and really speak volumes to the amount of work that he and his group have done. And in particular, he's going to be talking to us about, the title is Novel Cognitive Stress Paradigms in Early AD Detection or Preclinical AD Detection. And this is something that is, I think, very relevant and important is in considering the way we do our cognitive testing and how it's in these nice sterile environments, no distractions, quiet outside. Signs on the door, be quiet, testing ongoing, and really just trying to bring in the more ecologically valid aspects of cognitive testing. And so he's going to tell us more about that, since my description has been really kind of poor. So please join me in welcoming Dr. David Loewenstein to our ADRC, Shiley-Marcos ADRC seminar series. Dr. Loewenstein?
Thank you so much. We can switch to the next slide. Thank you so much for those very generous words. In terms of pedigree, I would be best described as a mutt for all of you who know me. The only disclosure I have is I'm a co-inventor of the intellectual property used in this study. At the University of Miami, every time you create a test or a paradigm, they automatically, it becomes intellectual property of the university. So I'm a co-inventor of that. Here's just some of the acknowledgements, some of the R01s and the P50s and P30s that have funded this research, as well as the state of Florida Department of Health. Next slide. Now, all of this research is about people. All of us involved in Alzheimer's disease research, we could not do anything without the generosity of the volunteers and the participants and their family members who come in year after year, dedicating their precious time and effort to try to help us understand the underpinnings of neurodegenerative disease. So we always like to start with this slide because we are nothing without the generosity of our participants. Next slide. We have a number of state, national, and international collaborators. You'll see some of them as I discuss this data, but this is just to show that we certainly are not an island. We really function as a village, and we have many, many rich collaborations, and we want to thank all of our collaborators. Next slide. So most of you are very well aware of the fact that by the time a person has been diagnosed with dementia, significant deterioration has already occurred in many areas of the brain. So by the time somebody has a major neurocognitive disorder or dementia, a lot has occurred in the brain, and so much multi-system degeneration has occurred, there's very little we can do at that point. And that's been very frustrating for brain researchers. So for us, the detection of the earliest stages of Alzheimer's disease and related disorders, we think is very, very important because number one, we can engage in prevention efforts, or we can try innovative new therapies that can be initiated before significant brain degeneration has occurred. Now, it's probably not going to be amyloid alone. It's going to probably be eventually cocktails, very much like HIV. The amyloid agents alone don't cut it, but there's very, very many investigators doing very innovative research, and we really have to detect very early memory processes in Alzheimer's disease. I just want you to know, we've had people who have had head full of amyloid and some with tau that have gone many, many years without cognitive symptoms. I also might add that a very significant percentage, up to 25 or more percent of people over the age of 85 that come to autopsy have Alzheimer's pathology, and yet cognitively they've been doing pretty well during life. So that's a very important, because of cognitive reserve, because of resilience, certain people don't manifest cognitive deficits despite clear biological damage to the brain. There are a number of terms that we use to describe things that are before amnestic MCI. Amnestic MCI, first defined by Ron Peterson and later by others, really describe somebody who has memory or multi-domain cognitive impairment, but without enough significant functional impairment so that they're deemed quote unquote demented. So the real distinction between MCI and dementia really is your degree of social and or occupational functioning. That is a little bit problematic because many studies show people that have MCI, particularly late stage MCI, have brains that look very similar to those with Alzheimer's disease. And in certain studies, 40% or more of people who have been diagnosed clinically as MCI without significant social and or occupational functioning actually have functional deficits when you test them objectively or you use some other very good standard outcome measures. So all of this means that Alzheimer's disease is on a continuum. John Morris was famous for saying, you don't convert to Alzheimer's disease, you progress to Alzheimer's disease. And so if there's things called amnestic MCI, there's also cognitive states that occur before a, if we could go back to the next slide, to the last slide, thanks. So in 2012, Ranjan Dvorin and I defined two states called pre-MCI, and that was a state where the person either after a very extensive clinical interview with an experienced neurologist or geriatric psychiatrist and using the CDR, the person was thought to have declined, and an informant agreed with them, yet their neuropsychological results were normal. They didn't meet formal definition for amnestic MCI because the clinical syndrome was not confirmed by neuropsychological testing. There was another type of MCI where clinically the person and their informant said the person had not declined, they were operating perfectly, yet there were certainly signs of neuropsychological deficits. So we call those pre-MCI clinical, pre-MCI neuropsychological, and we followed these people from 24 to 36 months and determined that these individuals progressed to a formal diagnosis of amnestic MCI and dementia at a 6 times greater rate than normal controls. So we call those pre-MCI. My friend and colleague, Mark Bondi, and his crew have identified, most recently, objectively defined subtle cognitive deficits, a beautiful article in Neurology, looking at people, looking at process scores, looking at different subtle objective cognitive measures other than what we usually look at. And what was so interesting is over a 4-year period, Mark can correct me if I'm wrong, over a 4-year period, these people relative to the controls had a greater accumulation of amyloid in the brain, and they had increased entorhinal cortex thinning relative to controls. So Thomas Bondi et al. Really showed the value of process-oriented kinds of measures, and that you can deconstruct measures and find cognitive decline well beyond traditional measures or metrics that we use. And of course, for all of you who use NAC, which we all do, who are part of ADRCs, there's impaired not MCI. And those are people who are not cognitively normal, but they do not meet criteria for an ESSIC MCI. So this is just to try to convince you that there are states that are prodromal, preclinical, and we're going to talk about those today. Next slide, please. So we're going to talk about cognitive stress tests. As was very eloquently described in the introduction, you know, in real life, neuropsychological testing is done in optimal conditions. So people really don't have to multitask. They don't have to divide attention. There's a do not disturb sign on the door. And yet, if you look at somebody, for example, with a head injury, they can do pretty well on standard neuropsychological tests sometimes. And yet, if you put them in an office where they're at a reception desk, where they're on the phone making an appointment, where they have to multitask, divide attention, have executive function, the doctor comes in and says, oh, I need this refilled. These 3 different things, these people fall apart. So even though the neuropsychological tests given in very pristine conditions don't show the deficit under real world stress, so we call our tests cognitive stress tests, and you can see our little brain riding the treadmill, and that's kind of what we're into. Next slide. So the question is, can we identify a marker during the preclinical stages of disease? And if you could click, yeah. So we're trying to look at, you know, yes, amyloidosis, tau, certain synaptic changes may occur, but can we identify cognitive markers much earlier in the preclinical stages of the disease, well before, for example, neuronal degeneration on MRI, or thinning, or volumetric loss? Next slide. So this is the Lassie cognitive stress test. And this will date some of the neuropsychologists and neurologists and other scientists on the, if you remember Lassie, you remember he was a very lovable dog. So we named the Lassie after Lassie, our dependable friend, and that's our Lassie. Next. Lassie really stands for Loewenstein-Acevedo scales for semantic interference and learning. And it's a controlled learning paradigm of 15 words using 3 categories: animal, fruits, and musical instruments. Why is it controlled learning? Because we tell them beforehand what the categories are going to be. So unlike the CVLT, where the person has to kind of figure out what the categories are, right? You actually control the learning by saying, look, these are the 3 categories we're going to be giving you. And so you're giving them 15 words, and you're actually helping them to organize the encoding. Category cues are provided at both acquisition and retrieval stages of learning over 2 trials. And we feel that this really provides maximum storage of information, and a number of his studies have shown that. Oh, please go back. Okay. Now, a second list of semantically related targets is presented twice with cued recall. That's very, very important because 3 identical categories, but 15 different targets, and that produces a phenomenon called proactive semantic interference. That is the new learning is interrupted by the old learning. That is proactive semantic interference. And failure to recover from proactive semantic interference, or what we call FRPSI. The failure to recover from proactive interference means that even though we give repeated learning trials of the new information, the person cannot get back up to criteria because the old learning continues to interfere with the new semantic learning. And what's important is recovery from proactive interference is really not measured in other paradigms in such an extensive way. Next. Next. So just the Reader's Digest condensed version of the Lassie, 3 semantic categories: fruits, articles of clothing, musical instruments, controlled learning. Next. We present list A targets, 15 words, 5 per semantic category. We have 2 presentations, 2 cued recalls. Next. We then present list B targets, 15 words, 5 per semantic categories, but they're the same semantic categories as the first list: fruits, articles of clothing, and musical instruments. And then, of course, we then have free and cued recall of these B targets that allow us to look at proactive interference and recovery from proactive interference. Next. Okay, and you just see that second presentation of B targets helps us to determine whether the person can ultimately recover from proactive interference. Next. And then, of course, we look at retroactive interference, and although it's not on the graphic, we also look at delayed recall, because being good neuropsychologists, delayed recall and rate of forgetting still is important, but not as important as these other measures on the Lassie. Next. Next. So we're going to look at salient early cognitive markers of Alzheimer's disease. Next. Semantic interference. Next. So this is PSI. Remember, previous learning inhibits new learning, and in the semantic sense. Failure to recover from semantic interference. Next. Retroactive interference, that's the new learning. The list B targets inhibit the recall of previously learned information. Next slide. Oh, semantic intrusions, very, very important. So in addition to all of these raw scores, intrusion errors or process errors, as Mark Bondi and my other colleagues would say, are very important, and we're going to show you just how important they are. Next. Okay, next. Next. So the Lassie has been shown to be associated with early detection of Alzheimer's disease, associated with biomarkers of amyloidosis and neurodegeneration, total and regional amyloid load, ERC, which is entorhinal cortex thickness, and HPC, hippocampal atrophy. It's also translated in Spanish, cross-culturally validated, and is used in a number of countries around the world. And if you want to look at all of these studies, a great review is our review and assessment in 2018. Next slide. So we've done a number of comparisons looking at the Lassie versus other measures. And from a biological perspective, um, failure to recover from proactive interference and proactive semantic interference seem to have much higher correlations with biological measures than do regular things such as the Hopkins verbal learning tests, story passages, other memory tests, either figural or verbal. This is a study done by Matias Gayu in Madrid, one of our colleagues. And basically what they did is with PET confirmed, very early Alzheimer's cases confirmed by FDG PET, they basically compared the LASI to what we call the European standard. This is what Bruno Dubois and other people use in Europe, and this has been what we call the European standard, the free and cued selective reminding tests. And you can see the LASI performed it was quite superior in terms of the area explained under the ROC curve and associating people with the earliest Alzheimer's disease with controls. Next. Now, I talked about intrusion error, process errors. In essence, a short-term memory error is where an individual produces a word that is not on a target for recall. Now, on a lot of tests, so for example, if you look at the Ray Auditory Verbal Learning Test, and you look at the California Verbal Learning Test, the Hopkins Verbal Learning Test, the SARAD battery, you can intrude items, but the items themselves don't lend themselves to a lot of intrusive errors. So they do occur, but they occur at a very low frequency. And what the LASI was designed to do was to actually maximize the chances that intrusion errors or these process errors would occur. So in Alzheimer's disease, semantic intrusions may be associated with reductions in encoding and storage capabilities, poor inhibition, or inefficient self-monitoring abilities, executive function. So we're moving beyond episodic memory, and now we're going into executive function. So whereas most of these list learning tests have been thought to reflect episodic memory, semantic memory, we're now looking at intrusion errors as being related to executive dysfunction, and that area, that shady area with episodic memory, working memory, executive function, and then lastly becomes a more complex test. We have found in our hands semantic intrusion errors may be among the earliest behavioral markers of elevated Alzheimer's brain pathology. Next. So if you could just click on do a few clicks and we'll get the whole slide to show. If you could just just click until the whole slide fills out. Okay. Okay, you're doing a wonderful job. Thank you. Okay. So click one more time, and we're there. Great. So just take the semantic category of fruit on the LASI. The list A targets, I've listed 4 potential targets, right? So the person on list B recall recalls the grapes and they recall peach, but they intrude the list A targets, which are plum and banana. And Torres et al. In our group found that about 70% of intrusion errors on the LASI are taking a list A target and substituting it for a list B target, such as plum and banana, which were on list A. Another 15% are targets that represent the same semantic category, but are on neither list. Okay, next. Now, one of the things that we did with intrusions was, this was very nice because it was highlighted by the National Institute on Aging. And that's always very good when your funding agency actually does a press release on your work, because it makes your program manager very happy. This was a study done in neurology, and I'll describe it to you briefly. Next. So what we did is we took a group of 3 participants, okay? All of these had very carefully worked up people, had amnestic mild cognitive impairment. Now, those who had MCI-AD, we had 34 of those people. They had all the clinical features of Alzheimer's disease. They had hippocampal atrophy, and they were also amyloid positive. They were not only amyloid positive in terms of visual read, but their centiloid values were, in a range that it was very clear they were amyloid positive. And we had tremendously high inter-rater reliability in terms of the reads. So we presume that these 34 people had underlying Alzheimer's disease as the presumptive pathology. The second group looked like Alzheimer's disease. We thought they had Alzheimer's disease. They had hippocampal atrophy. They had clinical histories and courses of Alzheimer's disease. But guess what? They were amyloid negative, totally amyloid negative. So they had no amyloid whatsoever. At that time, we did not have tau scanning, but they certainly had no amyloid. And we thought they had Alzheimer's disease. And so we have to call them SNAP. In the literature, this is called suspected non-Alzheimer's pathology, with the notion that if you're not even close, these people weren't on the threshold, they had no amyloid visible in the brain, okay? And then you had mild cognitive impairment that were associated with other etiologies, and you can see the different neuropsychiatric and neurological etiologies. We had 25 of those people. And what was very nice is all of them were amyloid negative. So at least we knew that no Alzheimer's patients or somebody with Alzheimer's disease, particularly if you have somebody like with diffuse Lewy body disease, where the co-occurrence of Alzheimer's disease is high, at least we knew. So we have one group that's amyloid positive, 2 groups that are amyloid negative, SNAP or MCIs of other etiologies. Next slide. So I just want you to focus on the red on the bottom and just look at the amyloid positive group. You can see there were a great many more B1 and B2 semantic intrusion errors when they were trying to produce cued recall of cued B1 and cued B2. So as you can see, significantly more intrusion errors than people who had SNAP and no amyloid, and other etiologies with no amyloid. So it really did seem that even after adjusting for age, MMSE, language of testing, clearly, if you had MCI and you adjusted for overall severity of illness, or any other covariates, the people who had amyloid positivity had far more B1 and B2 intrusions. Next. And this is just an area under the ROC curve, which was about 0.80, distinguishing the amyloid positive group to the other etiology amyloid negative group. So this is a pretty decent ROC curve for intrusion errors. Okay, next. So we're now going to talk about LOAD and OLOAD. LOAD is late onset Alzheimer's disease, and it's very important because 98% of the AD cases that you're ever going to see, the clinical symptoms emerge in the 7th decade of life or later, okay? And age and family history are identified as main risk factors. And children of load are 6 times more likely to develop Alzheimer's compared to individuals without a family history of Alzheimer's disease. Many load individuals have no ApoE allele, that is E4. We all have ApoE alleles, but most of them are not heterozygous or homozygous for E4. And next slide. So this was done in Buenos Aires with Salvador Guinjon's group. There was only an N of 21, so these are very preliminary findings. But he took asymptomatic middle-aged children of an adult that was diagnosed at the Flenny Institute, a very famous neurological institute in Buenos Aires. 50% of the middle-aged children of load made semantic intrusion errors versus 0% of normal controls. So normal controls never made a semantic intrusion error, never did, where 50% of supposedly asymptomatic middle-aged children of load made semantic intrusion errors. And of course, these were mostly B2-cued recall or failure to recover from semantic interference. Now, there's some interesting findings, because in these particular people, there was presence of FDG alterations in the absence of significant amyloid deposition. And this may open up a very nice conversation about Brock and Brock's original work, looking at people in their 30s in the entorhinal cortex, right? Where there was Alzheimer's pathology long before there was amyloidosis. So even though amyloid is something that occurs very, very early in Alzheimer's disease, in these particular subjects, and Lisa Mosconi and other people have found similar things, there may be FDG alterations in the absence of significant amyloid pathology, particularly in younger people. And that's worth talking about, because we do think that Alzheimer's disease is a multi-system kind of disorder. What was most important is that intrusion errors on failure to recover from proactive interference, QB2, was associated with an inverse relationship between intrusion errors and connectivity between the hippocampus, the insular cortex, the posterior cingulate, the dorsolateral frontal, the precuneae, and the anterior thalamus. So you can see these cortical limbic disconnections in these asymptomatic people who are children of people who have, they were ages between about 30 and 59. They were about between 30 and 59 years of age. And you can see, you're seeing that these semantic intrusions are really associated with this cortical limbic disconnectivity in the absence of amyloid. Okay, next. So we had a clinical observation that there's certain people that just score really low on the Lassie, right? You've seen people on memory tests, they just score very low. So even if you only are naming, let's say you can only recall 2 objects of 15 on a recall trial, okay? And you have 1 intrusion, okay, well, 1 intrusion is 33%. What if you have 6 correct, but 3 of those, but 4 of those are intrusions? That's 40% of your total responses are intrusion responses. So one of the clinical observations were people who made low base rate responses didn't make as many intrusions, And thus looking at the absolute number of intrusions often didn't capture what went on. Next slide. So we came up with the pi ratio. We like dogs and we like food. So we have the Lassie and we have pi. And the percentage of intrusion errors was just the total intrusion errors divided by the total intrusion errors plus total correct responses on either queued B1 or queued B2 of the Lassie. So that's pi. Next. Okay. Now, basically, I just want to, we'll go through this very quickly. We've done a number, this is in PRESS, International Psychogeriatrics, where we just looked at direct and indirect paths in terms of age, ApoE, amyloid, MRI, neurodegeneration. And all that I want to say is that QB1 and QB2 intrusions were the best predicted by amyloidosis after you controlled for all these factors, okay? And even, next slide, even when we put MMSE into the model, right, same thing occurred. So if you looked at the standardized coefficients, there was a direct effect between amyloid load and neurodegeneration and B2 intrusions that were present, and ApoE did not seem to exert any influence on intrusions, but did its work through the through amyloidosis. So if you had higher ApoE, you had higher amyloid, and that translated. So this was nice because confirmatory path analysis allows you to look at things such as age. Age is uncaused, for example, so you can look at age. You can look at other covariates in the model. Next slide. And these are unstandardized coefficients, but just going to show you that path analysis is a very, very nice way, or LISREL if you do linear structural equation modeling, of partitioning out direct versus indirect effects. Next. So what are some goals? We want to track clinically meaningful outcomes over time. We want to see the convergence with biomarkers. We're looking at CSF, blood-based amyloid, tau PET, and MRI neurodegeneration using an ATN framework. We want to see if the Lassie may be helpful in clinical trial settings, to look at the effectiveness of emerging therapeutics during a real therapeutic window, and also to identify optimal enrollees in AD prevention trials, right? You can't do an amyloid scan on everybody, but maybe you can pre-select people that might be better candidates. And we're also working with web-based, computer-based assessments of the Lassie. Dr. Rosie Curiel has developed the Lassie BC, which is a web-based computerized version of the Lassie, which is really cool. Next. So is pi useful to predict cognitive change? And I'm going to give you the Reader's Digest condensed version of this. Next slide. So you can keep going. Okay. So we had people who were stable, normal for several years. We had people who had pre-MCI who either reverted to normal. Okay. You never convert, you just revert or progress. And some of them progressed. And then we had amnestic MCI who progressed to dementia. Next slide. So you can see, if you look at the people who had amnestic MCI who progressed to dementia, and you looked relative to the stable normals, you can see the arrows under the ROC curves are phenomenal for the pi ratios. To be expected, right? But still pretty good. So next slide. So you can see, using that pi cutoff that we established, 13.7% of normals It exceeded the pi cutoff. Those pre-MCI people who did not progress but reverted over several years back to normal, 12%, very much like the cognitively stable normal. But look at the pre-MCI that progressed to amnestic MCI, almost 4 times that of the people who reverted. So you can actually predict, at least in this small study, progression to amnestic MCI versus reversion to cognitive normal in those who had pre-MCI. And of course, 83.3% of people with amnestic MCI who had a high pi ratio progressed to dementia. Okay, next. Okay, we can skip this. Okay, just want to show you Liz Crocco basically has a brief version of the Lassie. It's actually in press in the Journal of Alzheimer's Disease, not International Psychogeriatrics, but we have a 8-minute version of the Lassie, which incorporates the most powerful elements that gives you the same sensitivity, specificity, positive and negative predictive value. And many people like this briefer form of the Lassie because it gives you more bang for the buck. You don't have to give a 15 or 20-minute test. Next. Some recent papers and work, we're working with culture fair versions. We have versions that have been, that show minimal cultural bias with African Americans, Cap et al. 2020. As I spoke about, Rosie Curiel and her group have done wonderful job of computerizing many of these cognitive stress tests. We're now working on development of Lassie equivalent parallel forms and developing a task-based Lassie for fMRI studies. Next. Okay, I'm not going to summarize except to say that we do believe that percentage of intrusion errors, and process scores on measures such as the Lassie and other measures have tremendous potential and picking up decline much earlier than standard neuropsychological tests. Next. And this is just as our CNS team at U of M, and this is one of many teams we work with, but this is our local group, and it takes a village. Thank you so much for your time, and I'll entertain any questions you might have.
Very good. Thank you, David. And if we can unmute everyone, Emily, then we can bring in some questions. I'm going to go ahead and take the liberty of asking a quick question, simple question, I think, is we do big population studies in our group. Yeah. And so when you mentioned a brief Lassie, it kind of pricked my ear. So you said that journals or that article is coming out in Journal of which? Alzheimer's disease?
Journal of Alzheimer's Disease, and we can send you a preprint.
Oh, that'd be wonderful. Yeah, I'm very curious to see that. Again, we are always trying to balance participant burden with bang for buck, as you said. So exactly. Very intrigued by that. So now that everyone's coming off mute, I want to open up the forum to questions for Dr. Loewenstein.
I just wanted to mention, Hector, I allowed everybody to unmute themselves, but I left people who may be double tasking on mute so we don't get background noise.
Very good. So we have about 10 minutes for questions, so please go ahead.
Yeah, I have a question. David, that was a great presentation. I really like the test a lot, and the idea behind it I think is great.
Thank you.
And my question was, people have talked about intrusion errors being related to cholinergic function. And I was wondering if you've ever looked at the relationship between Lassie performance and cholinergic function, and whether or not it might be sensitive to cholinergic medications like Aricept. And so what are your thoughts about that?
That is just a wonderful, wonderful question. Actually, in 1989, we got our start in developing intrusion errors as a measure of cholinergic response. And a number of people have looked at this in terms of actually anti-cholinergic stress tests. David Snyder, not David Snyder, Peter Snyder has done some of that work.
Right.
And so have we looked at it in terms of donepezil and the Lassie? No, but it's a great question. Yeah. Yeah. And obviously, for many years, Alzheimer's disease was thought to be a cholinergic deficit only. And now, you know, we have figured out that the reason donepezil doesn't work for too long is the fact that you can put all the high octane gas you want into the tank, but if the engine and the motor isn't working, it's not going to do too well for you. Great question. Thank you.
Sure. Really excellent question. It makes kind of begs the question, if one is taking anticholinergic drugs, whether or not you might see some exquisite sensitivity in that paradigm. But anyway, are there other questions for Dr. Loewenstein?
Great talk, David. I wonder if I could just throw out there to get your opinions on, you mentioned the idea that perhaps we're lurching towards a cocktail eventually with respect to treatment of Alzheimer's disease. I wonder if you might opine on the on how your data may fit within the amyloid cascade model, or alternatively Brock's staging scheme, in which he sort of touts tau as the early emergence, and that amyloid comes in a bit after tau. And I wonder how your data may jive with one model or the other.
What a fantastic question, Mark. One of the reasons we have expanded our tau imaging capacities, and I didn't present that data because we just don't have enough subjects yet, is what we're trying to do is we're really trying to look at the ATN model in much more detail. We not only have PET-based biomarkers, we have CSF biomarkers, and we're now moving towards blood-based biomarkers. I think there is a tremendous debate in the field as to, so for example, morphologically, if you have a E4 homozygous infant, morphologically, certain studies have shown their brains look different than children who do not have the E4 allele. So if you're homozygous and you're an infant, so what if we conceptualize Alzheimer's, here's something wild, as maybe a neurodevelopmental disease? What if the brain has certain vulnerabilities, and the vulnerabilities may involve amyloidosis, which is kind of the earliest kinds of things. Many people believe things happen earlier, we just don't measure it very well. Tau, you know, we know people in their 30s have tau pathology in the medial temporal lobes, long before amyloid is ever collected. So I think there are a large number of scientists that believe tau has a role. Then the question is, well, what's the goal of pre and post-synaptic kinds of changes that are associated with other things? How does microglial activation figure in? How does inflammation figure in? So I think what's happening is this is a process that just doesn't involve amyloid or even tau. It's microglial activation, it's oxidative stress, it's many kinds of different factors that I think converge together. And I think this notion that amyloid basically is associated, 25 years before the disease. Well, guess what? A lot of people with amyloid in their lifetimes never develop symptoms. And we even have people we've been following with amyloid and tau for 3 or 4 years. Now, they eventually will probably develop symptoms, but this whole notion of cognitive reserve, resilience, so it's a fantastic question. I wish I had more knowledge to opine on or with, but great question.
Yeah, thanks, Mark. And I have a question from Doug Galasco, who opined, "Great talk!" Exclamation mark. This is in the chat box. Do you have any data on the Lassie longitudinally, and do subjects show learning/practice effects that might make this aspect tricky to interpret?
Great question. So I did present some longitudinal data on the Lassie in terms of reversion from pre-MCI to normal versus people who actually progressed to amnestic MCI or dementia. So we do have some longitudinal data. We're currently evaluating our longitudinal data. We have about 1,000 people we've been following longitudinally. So we're doing that in the context of neuroimaging. Practice effects, wonderful question. It's a big problem with the Lassie and many, even the HVLT, which has 8 different alternate forms. Most of you know those forms are not necessarily equivalent. You can counterbalance them, but they're not all equivalent. And even when you do a test, if you don't do a multiple baseline, just being used to being given a test can cause practice effects, even if you have a different form. So we are developing right now 2 alternate forms of the Lassie, which we've worked, Dr. Curiel and I have worked very hard to try to get different semantic categories, equal difficulties. And we're in the process of right now trying to validate that, because practice effects, people argue, well, the absence of practice effects may mean that, you have some kind of neurodegenerative condition, and that is true, but practice effects are so strong that we do think that parallel forms are needed, and we are working on that. That's a great question. And it was a problem we were seeing in some of our longitudinal data, that even people with amnestic MCI were doing better over time. They were learning the test.
Just as a follow-up comment is that maybe those practice effects may be more telling in later years, as opposed to what you've been focused on of late, is this preclinical AD, MCI phenomena where you just really need to turn up the signal to get something meaningful in your studies.
Great point.
So,
or some of Mary McCulda's work showing the absence of an expected practice effect being predictive of decline.
Oh, absolutely. So for years, people have looked at the absence of a practice effect as being very predictive. So that is the question is, people like Terry Goldberg, for example, would argue that that's great and that's true, and it's been found in a number of different studies. But the question is, if you could get things where there's not, for example, Cogstate brags that, or they purport that they have 128 items on their international shopping list. Every time you generate a list for somebody, you're supposed to get an equal difficulty list out of those 128 that are never duplicated. Okay? Now, that's one way of dealing with it. I think practice effects can be diagnostic. I do think, however, the tremendous variability that occurs and the tremendous susceptibility, and most of us do not do lead-ins, right? Most of us do not do baseline and then a double baseline neuropsychological testing, because the greatest practice effects occur between T1 and T2. So so I think practice effects are fine. Alternate forms are probably better if we can develop alternate forms that work. And I don't know, Mark, what your opinion is, whether we can do that. I'm not sure.
Yeah, I think it's a difficult task. I'll just, with respect to the CVLT, one of the sneaky things that it does in a good way is that the target items are not the most prototypical exemplars of the category, say fruit.
Yeah.
There'll be things like apricot and kiwi, but not apples, oranges, bananas, that sort of thing. And so if one is forgetting material, they may be more inclined to elicit a more prototypical intrusion error. So I wonder if word frequencies may be having some play within your word lists as well.
That's a excellent observation. And the Lassie was designed to be a culturally fair test that could be given internationally. So we purposefully chose items that were more modal. So I think that's an excellent point.
So I have 10:01 now, and I think just there's so much interest to be yet the questions continue. For those who do need to leave, thank you for joining in this wonderful conversation and presentation by Dr. Loewenstein of Miami. And but if you have a few minutes, I think there's a couple more questions floating
Absolutely.
in. Oh, fantastic.
As long as you can tolerate me.
Well, as long as you can spare. This is from Zvinka Slatar, a neuropsychologist and psychiatry. She says, okay, you go back. She says, wonderful talk. Are you planning to develop alternate forms of the Lassie for the Spanish version test?
Yes. So what Dr. Curiel and I and our colleagues in Miami, Dr. Krakow, what we're trying to do, Dr. K, what we're trying to do is all of the forms that we develop in English will be developed in Spanish. Now, Dr. Curiel goes around to different Spanish-speaking countries and helps them tweak the items, because as ubiquitous as we'd like all fruits to be, it's amazing when you go to different parts of the world and Spanish-speaking, I've never seen one of these before. What is that? So the answer is yes. In our alternate forms, we are working on Spanish versions of that.
That's really cool. And I think this is for the devotees. This is the devotee group. But boy, we should talk, especially with Dr. Curiel, because in our cohort, we have Latinos from all over the Latin America. And we struggle with this question of a Pan-American Spanish, not necessarily tweaking one for each group, let's say Cubans versus Puerto Ricans versus. So, boy, I think we should probably talk because I think we could probably learn something from your group on this important part. Having first gone to Puerto Rico a few years ago, and people are calling these buses Wawas, I just like, what is that? But anyway, that's just one example of what you say in one country doesn't necessarily mean the same thing in another country, and sometimes, rarely, but you got to be kind of careful what you say. Other questions coming up? Going once, comments twice. Very good. Hopefully we'll be talking, Dr. Curiel and others. Thanks for your time. So farewell to Miami.
Thank you for having us, and have a wonderful day.
Yeah,
you too. Thank you, David.
Wonderful talk.
Thanks.
Adios.
Bye-bye.
Bye.
Bye.